The posterolateral corner is important for knee stability, particularly in patients with anterior cruciate ligament ruptures. Here we have three patients. One we will use to demonstrate some normal anatomy. Another patient has a severe injury to the posterolateral corner, and the third patient has a more minor injury. The process for evaluating the posterolateral corner is a four-step procedure. First, look for the fibular collateral ligament, then look for the popliteus, thirdly, look at biceps femoris, and fourthly, to see whether there's any abnormal edema around the posterolateral corner, because that points to a capsular injury. Now, often these capsular injuries are due to tears of the popliteofibular ligament, but we will discuss that in a little more detail when we come to our third case. So this is a normal patient. If we start with popliteus, inserts in the popliteal fossa, arches around the lateral meniscus, and then characteristically splits into these two tendons. Very easy structure to identify. Injuries can be avulsions from the popliteal fossa or musculotendinous junction injuries in this location. Important to appreciate that the sheath around the popliteal tendon communicates with the knee joint. So if you have an effusion, then fluid will pass along the popliteus tendon and will often gather at the musculotendinous junction. And it's important not to misinterpret that as a tenosynovitis or some other form of injury to popliteus. In fact, in some patients, if there's enough fluid and if there is pressure, it can actually rupture into the muscle belly itself, simulating a musculotendinous junction tear. So most times that you will see edema disseminated within popliteus, it's due to an underlying effusion rather than an injury. The fibular collateral ligament attaches to the femur just above the popliteal hiatus, and that then can be traced distally to its insertion into the fibular head. It often inserts in close conjunction with the biceps, and here you can see the fibular collateral ligament and the biceps coming together, and they often share a similar insertion. Biceps itself is a complex tendon. Remember, there are two heads, so there will be various combinations of two tendons, and each tendon often has several attachments into the fibula and tibia. So you will see a variety. This here is part of the biceps inserting into the tibia. So you will see multiple components to the biceps insertion. Sometimes the tibial components are dominant, more often the fibular components are dominant. The fourth step is to look for edema around the posterolateral capsule, and this often reflects an injury to the capsule or one of the capsular ligaments. Now, the fibular collateral ligament and biceps attach to the more lateral part of the fibular head. If you move posteriorly, you come to the attachment site of some of these ligaments. And here we can see a long ligament. In this case, it's probably an arcuate ligament. If the patient has a fabella, then this is called the fibulofibular ligament, but this patient doesn't have a fabella, so this will be the arcuate ligament. And close to that we can see another ligament which is shorter and arches towards the popliteus tendon, and this is the popliteofibular ligament. Sometimes it is stranded. It's not always easy to see in all patients. A useful landmark is often the inferior branch of the lateral geniculate artery will run over its lateral margin, and that's sometimes worth looking for. So the three steps are to look for the principal structures, popliteus, fibular collateral ligament, and biceps femoris, and then to look to see whether there's a tear of the posterolateral capsule and try to identify these capsular ligaments, of which usually there is a long ligament, either an arcuate ligament or a fibulofibular ligament, and a short ligament, which is generally the popliteofibular ligament. All right, if we move over to this patient here, we can see very quickly that there is a severe injury to the posterolateral corner. And this is very characteristic of what these injuries look like. Looking at the fibular collateral ligament, you can see it has become lax, curled back on itself as it's been avulsed alongside the biceps femoris. Sometimes the biceps femoris can be difficult to identify because as it has multiple insertional strands, these often become spread out, and the distal part of the ligament, the end of the ligament, becomes difficult to depict. But this is because there are multiple strands. So this is biceps coming down and the multiple avulsed strands. There's very often a little avulsion fracture. Sometimes these can be difficult to identify. There's possibly a little bit of the periosteum attached to the end of the tendon there. And if there's a fracture, you can often lose definition of the fibular cortex. And there's an impression here that the fibular cortex not quite as crisp as it is further around, and this is called an arcuate fracture. In this case, you can see the popliteofibular ligament waving around, become lax because it's separated from the popliteus, and the popliteus as well has become avulsed from its femoral attachment. So here we have a very complex injury to the posterolateral corner with really all of the ligaments we've talked about involved. One other structure that's worth appreciating in this area is the common peroneal nerve, and sometimes these two can be torn in conjunction with these severe injuries. The axial images are often better for assessing this structure, and if we just zoom in on the posterolateral corner, we'll find our common peroneal nerve, and we'll trace it around through the area of injury. And in this patient, we can see that it remains intact and in continuity, but it's an important structure to look for in these patients with severe injuries. If we come to this patient, this is a patient with a relatively minor injury. When we examine the principal structures, we can see that the popliteus attachment is present and correct. The fibular collateral ligament and the biceps are both present with normal attachments onto the fibula, but we have the impression that there is some soft tissue edema in this location, and this is the first clue that we get to the presence of a capsular tear. If we look at the sagittal images, we can also see that it's often easier in relation to the fibula, and we'll see there's abnormal fluid outside the capsule in this location. So this is a clue as to the presence of a posterolateral capsule injury. Now we can then start to look for individual ligaments, and we may or may not be able to identify whether there's a specific ligament torn. If we go to the back of the fibula, where we expect to see our popliteofibular ligament attach, we can see that perhaps not quite so clearly defined. And this is probably a tear of the popliteofibular ligament. But the main conclusion is that there's abnormal edema. Here we can see the edema defining the lateral branch of the inferior geniculate artery, which is a paired structure, which we've mentioned before in relation to the anatomical location of the popliteofibular ligament. So we conclude here that there is an injury to the posterolateral corner. The principal structures are intact. There is a tear of the posterolateral capsule, and sometimes then we can say that it involves the popliteofibular or arcuate ligament, and sometimes we just have to conclude that there is a capsular injury and we cannot determine exactly which ligament is disrupted.